Good evening, everyone, and a warm welcome to all those who have joined us for today's webinar. I would like to extend my heartfelt gratitude to the general audience, patients living with Parkinson's disease, their caregivers, and family members for taking the time to be a part of this important session. Myself, Dr. Aditya Tangappan, Resident Medical Officer at VIAMS, and it is my great pleasure to join you today as the host of this webinar. Today's topic is breakthroughs in Ayurveda-based Parkinson's care, clinical evidence, research data, and Myopa insights. Parkinson's disease, progressive neurodegenerative disorder that affects not only movement, but also balance, coordination, speech, cognition, and emotional well-being. Managing Parkinson's disease is often challenging as conventional approaches primarily focus on symptom control. However, in recent years, there has been growing interest in integrative and Ayurveda-based approaches that aim to go beyond symptom management and address the condition more holistically. At VIAMS, we focus on combining classical Ayurvedic principles with modern clinical understanding to provide a more comprehensive approach to Parkinson's care. Today's webinar will be particularly significant as it will explore emerging breakthroughs in Ayurveda-based Parkinson's management, clinical evidence, and research data supporting these approaches, Myopa insights representing an important development in Parkinson's care. This session is designed not only for healthcare professionals, but also for patients and caregivers seeking clarity, hope, and scientifically grounded guidance. Now, my privilege to introduce our esteemed speakers for today's session. Dr. Vijith K V, Chief Physician and Managing Director at VIAMS. Dr. Neethu S Jith, Director and Women's Wellness Expert with special focus on Parkinson's disease. Their combined expertise, clinical experience, and research-oriented approach will make today's session highly insightful and impactful. Without further delay, with great respect and pleasure, I invite Dr. Vijith K V, Chief Physician and Managing Director of VIAMS, to deliver the keynote session and share his insights. Doctor, the stage is yours.
Good evening all for attending this webinar today. Thank you, Dr. Aditya, for the wonderful introduction. I hope I'm audible, correct?
Yes, sir. Good evening.
Yes.
Yeah. Thank you. So, today, can Ayurveda change the future of Parkinson's care? That is the main question here. And today, in this webinar, we will explore the clinical evidence and VIAMS integrated treatment protocol. So, the breakthroughs in Ayurveda-based Parkinson care, that is our the agenda today. So, when we speak of Parkinson's disease today, we must intentionally avoid reducing it to a simple neurotransmitter deficiency. For decades, Parkinson's disease was conceptualized as a dopamine depletion syndrome, primarily due to the degeneration of dopaminergic neurons in the substantia nigra pars compacta. While this remains central, contemporary research has profoundly expanded our understanding. So the Parkinson's disease is a progressive synucleinopathy. The pathological hallmark is alpha synuclei misfolding and aggregation. So these aggregates from Lewy bodies and Lewy neuritis, but importantly, they are not confined to the substantia nigra. They are observed in dorsal motor nucleus of the vagus nerve, to the enteric nervous system, to the locus coeruleus, to the amygdala, and the cortical regions in advanced stages. So this anatomical spread supports the Bragg staging hypothesis, suggesting a caudorostral progression. So the clinical implications are profound. Motor symptoms appear only after approximately 50 to 60% of dopaminergic neurons are lost. Before motor diagnosis or before we see a motor sign and symptom, the patient may experience constipation, REM sleep behavior disorder, hyposmia, subtle mood alterations, and autonomic instability. So these prodromal features may precede diagnosis by 5 to 10 years. So at cellular levels, we generally see mitochondrial complex 1 dysfunction, excess or reactive oxygen species, impaired autophagy, then neuroinflammatory and microglial activation, and protein clearance dysfunction. So thus, Parkinson's disease is not a linear dopaminergic problem. It is a system level neurodegenerative cascade. When we understand Parkinson's disease this way, it becomes clear that purely dopaminergic replacement, while essential, may not fully address the broader pathobiology. So now look into the screen that these are the dopamine pathways in the brain. That means the main dopaminergic tracks were dopamine X. So if the pathway is, see, these are the 3 pathways in the brain. So the first pathway is the nigrostriatal. So this nigrostriatal pathway originates from the substantia nigra and the target is striatum. So the function is the motor control, and the relevance in Parkinson's disease is degeneration or Parkinson's disease motor symptoms will be seen. When the pathway becomes mesolimbic, that is another pathway in the brain. So the origin will be VTA, ventral tegmental area, and it is going to the nucleus accumbens. And the function of that pathway is reward and motivation. And the relevance in Parkinson's disease is dysregulation, depression, and apathy in Parkinson's disease. If the pathway is mesocortical, then the origin is VTA, that is the ventral tegmental area, and the target will be the prefrontal cortex. And the function of this mesocortical pathway is cognition and executive function, and relevance in Parkinson's disease will be cognitive decline in Parkinson's disease. So now let us discuss the limitations of current therapy globally going. So like it is the most effective symptom. The limitations of current therapy is levodopa remains the gold standard, and rightly so. So it is the most effective symptomatic therapy we have. There is no doubt in that. It definitely improves bradykinesia, that means the slowness of the walking. Then rigidity and stiffness all over the body, especially in the neck, shoulder, hands. Hands we have lead pipe stiffness and cogwheel rigidity will be there. Then tremors, as we all know, tremor, there are different types of tremors: rest tremor, kinetic tremor, postural tremor, pill rolling tremor, different types of tremors are there, and the functional mobility. So definitely the levodopa carbidopa combination improves all these symptoms. So however, the several structural limitations remain. That is, the first is this levodopa carbidopa combination does not modify disease progression, and the second is long-term pulsatile dopaminergic stimulation may contribute to receptor sensitization. So motor complications develop in significant proportion of patients after prolonged therapy. So wearing off phenomenon leads to fluctuating response windows. Dyskinesias emerge due to maladaptive plasticity in basal ganglial circuits. This is not a criticism of levodopa. Don't think like that. It is a recognition of neurobiology. Furthermore, levodopa does not adequately address gastrointestinal dysfunction, which is a major symptom seen in almost all Parkinson's disease patients. Then sleep architecture disturbance will be there. Mood dysregulation will be there, and autonomic instability will be there. Thus, even when motor symptoms are controlled, patients continue to suffer from non-motor burden. So the academic question becomes, can adjunctive therapy support dopaminergic stability while addressing broader neurodegenerative mechanisms? That is a context within which our investigation emerged. Let's see through a traditional lens the Kambavada and neurodegeneration. So Parkinson's disease is known as Kambavada in Ayurveda. So Kamba means tremor and Vada means neurological problems. So in classical Ayurveda, this Kambavada is described under Vada Vyadhi. So it would be scientifically incorrect to claim that ancient text describes dopamine. They did not. However, they described syndromes characterized by tremors, rigidity, gait disturbance, and progressive weakness. So in Ayurveda, it is known as Majja Dhatu Kshaya, interpreted as depletion of nervous tissue vitality, conceptually parallels neurodegeneration. And the Agni dysfunction, that is Agni dysfunction means impaired metabolic transformation, parallels modern concepts of gut dysbiosis and systemic inflammation. Rasayana Chikitsa emphasizes tissue rejuvenation, then oxidative resistance and functional restoration. So this is not about the neuroscience into a classical language. It is about recognizing that degenerative frameworks existed historically though described differently. So modern systems biology increasingly acknowledges that chronic diseases require multi-target intervention. But Ayurveda historically adopted multi-component formulations. This conceptual overlap invites traditional exploration, translational exploration. Now, let's see why explore integrative intervention. So, Parkinson's disease is a neurodegenerative, neuroinflammatory, gastrointestinally linked, and systemically expressed. So despite decades of research, no therapy has conclusively demonstrated disease modification in large-scale human trials. Given this, exploring integrative strategies is not alternative thinking. It is responsible scientific curiosity, specifically strategies that provide dopaminergic support, that reduces oxidative stress, modulating neuroinflammation, and support gut microbiome health. So this may theoretically complement standard care. So as our flagship product, Myopa, was conceptualized within this translational rationale. This Myopa is not as replacement, not as opposition, but as exploration. So now let us see the overview or the formulation overview of Myopa. So the formulation integrates three primary botanical components. The first one is Mucuna, that is known as the velvet bean. So it contains naturally occurring levodopa. So unlike synthetic levodopa, it is embedded within a phytochemical matrix. So this matrix includes alkaloids, flavonoids, tannins, and other bioactive components. The second one is ashwagandha. Ashwagandha is very famous for the antioxidant effects, anti-inflammatory modulation, potential neuroprotective activity in experimental toxin-induced Parkinson's models. And the third one is Triphala. So the Triphala, it contains gallic acid, chibudinic acid, and ellagic acid. So Triphala has demonstrated as gut microbiome modulation and antioxidant properties, improved gastrointestinal mobility. So, milk-based bhavana processing is traditionally used to enhance lipid solubility. So, modern pharmacology recognizes lipid-mediated transport as relevant for central nervous system penetration. However, pharmacokinetic validation studies are required. The intention of this formulation is multi-dimensional. That is, dopamine replenishment, then oxidative stress buffering, third is gut axis modulation, and system level balance. Whether these theoretical mechanisms translate clinically is what we sought to evaluate. So the levodopa quantification and dose transparency of Myopa. So the HPTLC analysis demonstrated that 16.75% of levodopa content is there in Myopa. So at a 5 gram daily dosing, this corresponds to approximately 840 milligram natural levodopa. So dose transparency is critical. Botanical medicine must not rely on vague descriptions. Quantification allows reproducibility, comparative discussion, and pharmacodynamic modeling. However, the whole plant pharmacokinetics differ from isolated synthetic compounds. So absorption kinetics, metabolism, and peripheral conversion may vary. Thus, direct milligram to milligram comparison with levodopa carbidopa may be misleading. This requires controlled pharmacokinetic study only. So now everybody have a curiosity, and so many people ask me, Doctor, why no synthetic carbidopa is there in our Myopa? So the answer is very simple. Synthetic levodopa is paired with carbidopa to inhibit peripheral decarboxylation. But the whole plant macuna contains naturally occurring decarboxylase modulating compounds, MAOB inhibitory phytochemicals, and antioxidant cofactors. So some preliminary clinical studies have suggested that faster onset, longer on duration, potentially fewer dyskinesias when compared to Syndopa or Syndopa plus, which contains the levodopa carbidopa combination. However, we must avoid extrapolation beyond evidence. The absence of synthetic carbidopa suggested different pharmacodynamic ecology, not necessarily or inferiority. But this hypothesis requires pharmacokinetic comparison trials and plasma L-DOPA monitoring, dyskinesia tracking, and controlled crossover studies. Now, this is an open scientific question. So, we had done a 6-month clinical trial study design in our institution. So it is a single-centered study. 100 patients were included in this study. Hoehn-Yahr stages 1, 2, 3 was implemented in this study. Duration was 6 months. It was an open label design, and no placebo arm was there. So all participants completed the follow-up. So this is very important. No dropout suggests tolerability. However, open label design introduces expectancy bias. So placebo response in Parkinson's disease is known to be substantial, especially in motor skills. Thus, findings must be interpreted as explanatory. So the purpose was to generate hypothesis-driven data for future RCT design. So let us see the primary outcomes of UPDRS-3. That means Unique Parkinson's Disease Rating Scale. This is a scale globally using, and in that the third part, that is the tremor and other. So the baseline mean was around 32.5. Within 6 months, it came to 24.2. That means like minus 8.2 mean reduction was there. That means a more than 25% improvement was seen there. So in early Parkinson's disease, an 8-point improvement is clinically meaningful. Importantly, improvement was evident at 3 months and sustained at 6 months. So this suggests stable symptomatic effect. However, without a placebo control, we cannot isolate pharmacological effect from placebo or behavioral adaptation. So future double-blind RCT is really essential. Now, the age group analysis, how we had included in the study. So, a younger subgroup showed numerically greater improvement, but between a group difference was not statistically significant. That is, like this suggests insufficient power of subgroup analysis. So, possible explanations include greater neuronal reserve, less comorbidity burden than different disease duration, and better metabolic resilience. So this remains hypothesis hypothesis generating. So the secondary outcomes, that is the UPDRS part 2, that is secondary outcomes often receives less attention, but in chronic neurodegenerative disorders like Parkinson's disease, they may be equally meaningful. So the part 2 measures activities of daily living, including dressing, feeding, hygiene, turning in the bed, walking. So the observed improvements in UPDRS stage 2 indicates functional gain beyond motor examination. So this suggests that motor score improvements translated into real life functional benefit. And a PDQ, Parkinson's disease quality scale 39 improvement, reflects patient reported quality of life. So the domains include mainly mobility, emotional well-being, social stigma, cognition, and communication. So a statistically significant improvement in PDQ 39 suggests patient experienced perceived benefit. This is important because placebo effect can influence subjective measures. However, the combined improvement in objective motor skill, that is the UPDRS 3, and the patient reported outcomes strengthens plausibility. So the 85% responder rate indicates that the majority experience clinically noticeable improvement. However, responder definition criteria must be carefully analyzed in future trials. So in chronic neurodegenerative disease, even stabilizations can be clinically valuable. So if progression slows or symptoms soften, the patient independence may be preserved longer. So the future studies definitely must include minimal clinically important difference, NZID threshold, then blinder letters and video recorder motor assessments and independent adjunctions. So only then we can determine true effect magnitude. So the safety and tolerability in these cases, that means like safety is a paramount in dopaminergic therapy. So notably, no dyskinesia was observed over 6 months of time. There is significant given approximately 840 milligram levodopa equivalent daily, and we are able to reduce the dosage of the levodopa carbidopa combination, whatever it may be, whether it is Sindopa, Sindopa or Sindopa here, whatever it may be. However, we must interpret cautiously that dyskinesia risk often increases with longer duration. So 6 months may not be sufficient to observe long-term complication. There are some limitations because we had conducted this study in our centers. So no hallucinations or no psychosis were reported in this study. Orthostatic hypotension was not significant during this study. Laboratory parameters remained stable in this study. No hepatotoxicity or nephrotoxicity was observed in this study. Then high compliance, that is more than 90% suggest tolerability and palatability were acceptable. However, botanical variability may always be monitored. Batch-to-batch consistency is critical, and long-term surveillance studies must include dyskinesia tracing scales, psychiatric symptom monitoring, autonomic function testing, and plasma L-DOPA monitoring. So safety claims must always be time-bound and evidence-bound. So now let's see the laboratory validation of the flagship product, the Myopa. So heavy metals were within the limits, and microbiological safety confirmed, no pesticides or residues detected, and batch-wise quality control was there, and it has passed the European Union standard also. So this ensures patient safety, regulatory compliance, and batch reproducibility. So the botanical medicine must meet pharmaceutical level safety expectations. And the study limitations obviously there will be some limitation in each and every study. So this study was an open label, a single center regional cohort was there, 6 months duration was there, no placebo was there, no biomarker data was there, no imaging endpoint. So open label design introduced expectancy bias, observer bias, and regression to mean. So absence of placebo prevents isolation of true drug effect. So short duration limits long-term safety inference. So lack of biomarker data prevents neuroprotection claims. So these limitations are not weaknesses. They're definitely the next research phase. So future research directions, these are the, like it should be a multi-centered RCT. Then a double-blind study will be there, a biomarker evaluation will be there, a microbiome analysis will be there, and long-term dyskinesia surveillance will be there. So I'm concluding the segment 1. So during this concluding, I must say about this is an open label study demonstrated 25% mean motor improvement was seen. 85 to 90% responder rate was there. Favorable short-term safety will be there. No dyskinesia over 6 months will be there. However, it is exploratory. It is not definitive. It does not claim superiority. It does not claim disease modification, but it generates hypotheses. So integration must be evidence-driven, ethically guided, transparent, and collaborative. So the future of Parkinson's care may not lie not in choosing between systems, but in designing trials that allow systems to be tested side by side. Science must lead, patients must benefit, ideology must remain secondary. Thank you very much. Now I would like to invite Dr. Neethu for the insights of Myopa, our flagship product. Over to you, Doctor. Hello.
Namaste everyone. As Dr. Vijith explained earlier, to evaluate the clinical progression of Parkinson's disease in our patients, we use the Unified Parkinson's Disease Rating Scale. This is a globally accepted standardized clinical scale used to assess the severity and progression of Parkinson's disease. However, there is an important point to understand that a reduction in score in a single assessment does not mean that the disease has been cured. Parkinson's disease is not an acute condition. It is a chronic, progressive neurodegenerative disorder. Therefore, disease progression should not be interpreted as a single event, but rather as a trajectory over time. Instead of focusing on isolated numerical changes, we evaluate how the trajectory of disease progression evolves. For example, we look at functional improvements such as, is the patient able to eat independently with great ease? Do they feel more confident while walking? Do they require less assistance when dressing? Has their handwriting improved compared to before? What changes do family members observe in daily life? These real-life functional changes together represent the true picture of clinical progress. Let us discuss the observed pattern of clinical progression. During the initial phase, patient began to report subtle but meaningful improvements, such as slight reduction in tremor, mild reduction in muscle tone, slightly easier initiation of movement. For instance, a patient who is previously experienced significant tremor while picking up a glass of water might report that the tremor is now somewhat better controlled. For patients and families, this stage often becomes the first encouraging sign of change. This is not a dramatic improvement, however, it may represent the early neuropharmacological response to treatment. At around 3 months, the improvements became more noticeable. Observed changes includes reduction in rigidity, especially in the upper limbs, increased stride length, reduction in shuffling gait, and improved movement initiation. Previously, patient might have hesitated while beginning to walk or while rising from a chair. After 3 months, these movements appears more natural and easier. This may suggest that dopaminergic support within the basal ganglia circuitry is becoming more stable. We also observed improvements in fine motor coordinations, including better performance in finger tapping test, improved handwriting, greater ease in activities of daily living such as buttoning a shirt. These may appear like small improvements, but clinically they may reflect functional stabilization of the motor cortex basal ganglia loop. During this phase, patients often experienced increased confidence and improved independence in daily activities. This also helped reduce the psychological burden on caregivers. By the 6-month mark, the most notable feature was clinical stabilization. Previously observed improvements are maintained, symptom fluctuations appeared reduced, motor control became more consistent. This does not represent an overnight recovery. Rather, it reflects gradual motor stabilization. Typically, placebo responses show fluctuating patterns. However, the relatively consistent improvements observed here may indicate pharmacodynamic stability, although further control studies are needed. So, tell about the scientific interpretations. The timeline of improvement observed around 3 months appears consistent with the expected time frame of dopaminergic support mechanisms. The botanical formulation, Myopa, may support dopaminergic pathways and potentially contribute to improved motor control, reduction in rigidity, better management of bradykinesia, improvement in fine motor coordination. Additionally, anti-inflammatory modulation may also play a role, although this requires further studies and investigations. So remember this thing, in Parkinson's disease, improvement is not sudden. Progress typically occurs slowly and steadily over months rather than fluctuating dramatically from day to day. The stabilization observed over 6 months is therefore clinically meaningful. However, this naturally raises important some questions. What happens after 1 year or longer? Is there potential for long-term neuroprotection? Could there be disease-modifying effects? What is the long-term safety profile? To answer these questions, further scientific studies are essential. These should include larger cohort studies, longer follow-up periods, biomarker correlation studies, randomized control trials, multi-center clinical trials. So, coming to motor and non-motor symptom changes. When we think about PD, we often focus on motor symptoms such as tremor, rigidity, bradykinesia. However, in clinical practice, non-motor symptoms often have a greater impact on daily life. At baseline in our observations, approximately 50% of patients had chronic constipation, around 40% experienced sleep disturbances, nearly 30% report anxiety or depressive symptoms. Importantly, many of these non-motor symptoms may begin even before the motor diagnosis. This highlights that Parkinson's disease is a multi-system neurodegenerative disorder. And the scientific basis of the non-motor symptoms are, first is constipation. It is associated with the dysfunction of entering nervous system and gut microbiome imbalance, emphasizing the role of the gut-brain axis in Parkinson's disease. Second is sleep disturbances that are linked to brainstem dysfunction affecting REM sleep regulation. And the anxiety and depression may arise due to alterations in dopaminergic and serotonin pathways. During the study, many patients using Myopa reported noticeable improvements in several non-motor symptoms. This includes better bowel regularity, improved sleep quality, reduced morning stiffness, and a decrease in psychological stress with enhanced emotional stability. It is important to note that these findings are based on observational clinical reports rather than direct mechanistic evidence. However, certain components of the formulations have biological plausible effect. For example, Triphala may support gut mobility and help maintain microbiome balance, while ashwagandha is known for its adaptogenic properties, potentially acting through modulation of the hypothalamic pituitary adrenal axis. Taken together, these components may serve as part of an adjunctive integrative approach, supporting overall patient well-being alongside but not replacing standard dopaminergic therapy. Improvement in non-motor symptoms plays a crucial role in overall management of Parkinson's disease. These symptoms, such as sleep disturbances, mood changes, constipation, cognitive issues, often have a profound impact on a patient's daily life. When effectively addressed, they can enhance medication adherence, reduce caregiver burden, and significantly improve the patient's quality of life. Additionally, better control of non-motor symptoms supports greater functional independence and boosts patients' confidence. Therefore, Parkinson's management should adopt a holistic approach, focusing not only on motor symptoms but on the total disease burden to achieve meaningful and patient-centered outcomes. Then, quality of life outcomes among Myopa users extend beyond measurable clinical scores and reflect meaningful changes in everyday living. Clinical scales such as UPDRS Part 2 and PDQ-39 capture improvements that translate into better daily functioning, enhanced confidence, increased social participation, and improved emotional well-being. Many patients have reported practical benefits, including reduced hesitation while initiating movement, greater ease in rising from a chair, improved hand control during meals, and increased confidence while walking outdoors. Additionally, a reduction in tremor-related social discomfort has allowed patients to engage more comfortably in public settings. Notably, some individuals with YOPD, young onset Parkinson's, have even resumed part-time work, while others have reconnected with family and social activities. In the context of neurodegenerative disease, even maintaining clinical stability over a period of 6 months is considered a meaningful and positive outcome, underscoring the importance of comprehensive care approaches. Before interpreting these findings, it is important to consider the limitations of our study. This was conducted using an open label design, meaning both patients and clinicians were aware of the treatment being administered. As a result, the possibility of a placebo effect cannot be excluded, as patients who believe they are receiving beneficial therapy may perceive improvements in symptoms such as sleep, fatigue, or overall well-being. Additionally, subjective reporting bias is another important consideration. Certain aspects of neurological improvement, such as mobility, sleep quality, and overall quality of life, are partially based on patient experience, and awareness of treatment may influence both patient-reported outcomes and clinical observations. Therefore, these findings should be regarded as hypothesis generating rather than conclusive evidence. While the results indicate a promising direction, they require validation through more rigorous scientific research. Further studies should ideally involve randomized controlled trials with blinded designs to minimize placebo and observer bias. Furthermore, multi-center trials across different hospitals would enhance the generalizability of the results, and the inclusion of biomarker-based evaluations could provide objective biological support to the clinical observations. Such advancements will be essential to better understand the long-term efficacy and scientific value of this approach. Next slide is women and Parkinson's disease. When discussing PD, it is important to acknowledge that much of the existing scientific research has historically been based on predominantly male populations. As a result, our understanding of how Parkinson's disease manifests in women are still evolving. However, both clinical experience and emerging evidence suggest that women may experience the disease differentially from men, not only in terms of motor symptoms, but also in biological and psychological dimensions. In addition to the classical motor features, women with PD often report a higher burden of non-motor symptoms, including increased level of anxiety, depressive symptoms, and more pronounced sleep disturbances. These differences may in part be influenced by hormonal factors. Estrogen is believed to have neuroprotective properties, potentially offering some degree of protection to dopaminergic neurons during the reproductive years. Following menopause, the decline in estrogen level may alter disease expression, symptom severity, or progression in women. Another important consideration is bone health. Postmenopausal women are at the higher risk of osteoporosis due to reduced bone density. In the context of PD, where balance impairment and gait instability are common, this significantly increases the risk of falls and fractures. Therefore, targeted strategies for fall prevention and bone health management are particularly critical in female patients. In our clinical observations, motor improvements appear to be comparable between men and women. Interestingly, however, women demonstrated relatively greater improvement in emotional well-being, suggesting a potentially differential response in non-motor domains. This observation raises important scientific questions regarding sex-specific differences in treatment response, the role of hormonal imbalance, and the need for more individualized therapeutic strategies. At present, the aspects remain incompletely understood and warrant further investigations. Future research focusing specifically on women with Parkinson's disease will be essential to clarify these differences and to support the development of more personalized and effective management approaches. So coming to VIAMS integrative neurorehabilitative model. We know Parkinson's disease is often recognized as a movement disorder because of symptoms such as tremor, rigidity, and bradykinesia. However, it is a multi-system neurodegenerative condition that can affect many aspects of a person's life, including physical function, emotional well-being, sleep, digestion, and social participation. Because of this complex nature, effective management cannot rely on a single therapy alone. Instead, it requires a multidisciplinary and coordinated approach where different therapeutic strategies work together to support the patient's overall health and functional independence. At VIAMS, we follow an integrative neurorehabilitation model, which means we combine different types of therapies to support the patient as a whole, not just the symptoms. In this approach, Myopa is used as one part of a broader treatment plan rather than the only solution. This overall program may include therapies like Panchakarma to help reduce body stiffness and improve comfort, physiotherapy and gait training to maintain strength, balance, and walking ability, and speech and swallow therapy to support communication and safe eating. Psychological counseling is also included to help patients cope with stress, anxiety, and the emotional challenges of living with a long-term condition. In addition, proper diet guidance support digestion and overall health, while yoga and breathing practices can improve flexibility, relaxation, and internal balance. Next slide. Next, let us look at the safety observation among Myopa users. During the 6-month observation period, the treatment was generally well tolerated by patients with Parkinson's disease. Importantly, no serious adverse effects were reported. Complications that are sometimes associated with Parkinson's therapies, such as dyskinesia, involuntary movements, or hallucination, were not observed in the patient during this period. A small number of patients reported mild gastrointestinal symptoms, including occasional acidity, indigestion, or mild stomach discomfort. These effects were temporary in nature and did not require discontinuation of the treatment. Next, routine blood investigations remained stable throughout the study period with no clinically significant abnormalities detected. This suggests that the treatment was well tolerated at a system level. Overall, these findings indicate an acceptable short-term safety profile within the 6-month observation period. However, it is important to recognize that long-term safety cannot be fully established based on this duration alone. Further studies with larger patient populations and extended follow-up will be essential to confirm the long-term safety and tolerability of Myopa. Next slide. Let's discuss the possible mechanisms of Myopa. The benefits seen with Myopa may be due to several possible ways it works in the body. However, it is important to understand that these are still scientific assumptions, that is hypotheses, and not yet fully proven. More research is needed to confirm them. The first is protection from cell damage, that is antioxidant effect. In Parkinson's disease, harmful substances called free radicals can damage our brain cells, especially those that produce dopamine. Some herbal ingredients may act like natural protectors, helping to reduce this damage and support brain cell health. Second, reduced inflammation in the brain. Long-term inflammation in the brain is believed to worsen Parkinson's disease. Certain plant-based compounds may help calm this inflammation, which could protect nerve cells and slow down the damage. Next is supporting dopamine levels. Dopamine is a key chemical that helps control movement. In PD, dopamine level drop. There is an enzyme called MAOB that breaks down dopamine. If this enzyme is slowed down, dopamine can stay active longer. Some components of Myopa may help support this process, thereby helping movement control. Next is improving gut-brain connection. The gut and brain are closely connected. Many people with PD have gut problems like constipation or imbalance of gut bacteria. Supporting gut health may indirectly improve brain function and overall well-being. Next is improving overall body strength, that is Rasayana effect. While all these explanations are scientifically possible, they are not yet proven with strong evidence. They are early stage ideas based on current knowledge. To confirm how Myopa truly works, more advanced studies such as laboratory research, biomarker testing, and controlled clinical trials are necessary. In simple terms, Myopa may help through multiple supportive pathways, but we still need more scientific proof to fully understand its exact effects. Next slide, responsible integrative positioning. It is important to clearly understand the role of Myopa in this treatment approach. Myopa is not a cure for Parkinson's disease, and it should not be used as a replacement for standard neurological treatments. It is also not meant to go against or replace conventional medical care. Instead, Myopa can be used as a supportive herbal formulation as part of a comprehensive and integrative care plan. In this approach, different systems of treatment work together for the benefit of the patient. It is very important that patients do not stop their regular medications without proper medical advice. True integration means collaboration between different medical approaches, not conflict. When systems are opposed each other, it can negatively affect patient care. From a scientific and ethical perspective, this approach requires honesty and responsibility. This includes clearly reporting results, openly discussing limitations, and continuing research through well-designed studies such as randomized trials. And most importantly, the patient should always be guided with clear ethical communication. In simple terms, the goal at VIAMS is to treat the person as a whole, not just the disease. Help patients live better, move better, and feel better through a combination of therapies working together. In Parkinson's disease management, two key goals are effective symptom control and potential neuroprotection to help slow disease progression. In this observation, several encouraging trends were noted, including improvements in motor symptoms, certain motor symptoms like sleep and constipation, and overall quality of life. This 6-month safety profile was also reassuring with no major adverse effect reported. However, these findings should be interpreted with caution as they are preliminary and not definitive. Further, rigorous scientific studies are needed to confirm the true effectiveness, long-term benefits, and safety of the integrative approach. In conclusion, Parkinson's disease cannot be managed with a single treatment alone. As it affects multiple systems, the best outcome from a comprehensive and collaborative approach that combines medical care, rehabilitation, lifestyle changes, and supportive therapies. By addressing both motor and non-motor symptoms, the goal is not only to control the disease, but also to preserve independence and improvement quality of life. Ultimately, a patient-centered, multidisciplinary approach helps individuals live with greater dignity, confidence, and active participation in daily life. Thank you.
Okay, thank you, Dr. Neethu. So I think we can move to the question and answers session. If anybody have any questions, just unmute your mic and ask. We are ready to answer those questions, please. Dr. Aditya, any questions or suggestions in chat box?
No.
Okay. So as a conclusion, the major takeaways of today's webinar are Parkinson's disease is multi-systemic. So current therapies are symptomatic. Integrative exploration is scientifically justified. Myopa showed significant motor improvement in open label cohort. Favorable short-term safety profile. Study limitations acknowledged. Multi-center RCT is definitely essential, and integration requires evidence, not ideology. And here is the announcement of World Parkinson's Day 2026. We are planning for a mega webinar. So April 11th, World Parkinson Day mega webinar, Rewriting the Parkinson's Journey, Hope, Innovation, and Future Directions in Ayurveda-based neurocare. It will be like a 3-hour flagship event. So the core modules of that webinar will be the global burden of Parkinson's disease, Ayurvedic neuroscience signature session, a 12-year research journey, evolution of Myopa, Panchakarma plus rehab synergy, patient success stories panel, then advances in movement disorders. So a demo of physiotherapy plus speech therapy plus yoga sessions, and launch of 2026 Parkinson's care roadmap, including a Parkinson's diary, and multidisciplinary questions and answer session will be there. So the faculty will be, the complete VIAMS team will be there. Myself, Dr. Neethu, and Dr. Aditya, the resident medical officer, Dr. Aruna, the naturopathy, Dr. Prasad, the physiotherapist, Dr. Anup, the clinical psychologist. Everyone will be there in that webinar to attend the to deliver all the sessions. So please join. We will definitely let you know that with the Google Meet link. Thank you very much.
So is it on 16th April?
11th, sir. It's on April 11th.
April 11th. Their time, sir?
Time almost the same time will be there, like 6 to 8 will be there.
Okay.
And definitely we'll send you the link, sir. Google Meet link.
Is it a recorded?
Yes, definitely we will record it and we will share in our YouTube link as well.
In the social media, will it be available?
Yes, definitely, sir. We are conducting the webinars for the last 5-6 years, and all our webinar sessions recordings are available in our YouTube channel. Definitely, I'll share you our YouTube page link so you can go through that.
Yeah, but through the social media in the Facebook, I have to come to know about the links that which been shared. So in the middle of the season, I've been joined so far. So for all the beginning parts of the middle of the seasons and including the conclusion part, the all necessary important highlighted parts that should be included
Yes,
as
sir.
the most important, essential, and informative parts in the social media or all other communicative channels as well.
Yes, sir. It is all available in our social media handles, including Facebook, Instagram, YouTube, and everything.
That's the most important. Yeah.
Yes. And you can watch our all webinars in our website also. The playlist is there.
Okay, 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 sure.
We'll share you the link, all the details, sir. Thank you. Anybody have anything to ask? Please unmute your mic and
Doctor,
listen. Yeah.
are you planning a 3 months treatment for patients?
No. That was a 3-month study we had conducted already.
Ah,
Not a 3-month continuous treatment will be there, but not a 3-month inpatient treatment will not be there.
oh.
Inpatient treatment will be like 3 to 4 weeks of time. That is enough.
Okay, okay, sir.
That 3 months is a study, sir.
Hello.
Yes, sir.
My left leg is dragging while walking.
Okay. Do you have any tremors in any parts of your body?
I have Parkinson problem. I already consulted you. I have Parkinson problem.
Okay. You have tremors?
Tremors also there.
Okay.
But
Okay.
suddenly left leg is dragging. Sometimes it is good. Sometimes
Okay.
it is suddenly dragging.
Okay. Okay.
It is due to Parkinson only. Any other reason?
Okay. Yes, sir. Definitely, we can address that. Kindly drop your contact number in the chat box so that we will connect you tomorrow morning itself by any of the doctors in our institution.
Okay.
Yeah, there is one message from Parandeep Singh, sir. Let me explain all this to my manager. Okay, thank you, sir. You can explain and you can come back anytime, sir. You're most welcome, sir.
That's all. Good evening. How are you?
Yeah, good, sir. Good. How are you doing?
Very good. Very good. We have asked a few times that Manjinder, she have issue with the stiffness on the liver side.
Yeah.
And I will ask if in the next seminar you can do some more explanation for that and for the reason for this stiffness. It's not going from long time.
Okay, sir. We can do, sir. No worries about that. Did you fly back or you're still in here?
I will fly back, but Manjinder will be here. She's not going. She will stay here in India.
Will be here. Okay. So I think Dr. Neethu will get connected to her.
Okay.
No problem. Okay. Thank you, sir. Thank you.
Doctor, I need an online consultation within 1 week.
Yes, sir. This week we can plan. No
Okay,
problem.
okay.
Okay. Okay, I think the questions are over, so we can wind up today's session. So thank you all for. Besides Pankaj Kumar has asked, besides Myopa, what are other products for? Sir, we have a lot of products for Parkinson. The Myopa is just a common medicine who can use like in any type of Parkinson or any type of neurodegenerative diseases or even in movement disorders. So we have specific medicines for Parkinson disease. Please contact or please drop your contact number. So any of our healthcare advisors will definitely contact you.
Thank you, sir.
Thank you.
I congratulate you and your group to present such things in audio, social medias.
Thank you, sir. Thank you very much. Yes, Arka Samandasa, is there any neuromedicine for? Yes, we have, sir. We have. That's our doctor's direct number, so you can contact in that WhatsApp number 7034992442. I repeat 7034992442. WhatsApp is also available, so you can send just a hi message. Any of the doctor from our team will contact you shortly.
Sir, I sent 3 videos. Have you?
I was busy with webinar. Definitely tomorrow morning for the first thing in the morning, I'll look into it and I will reply to you, sir.
Okay, sir. Thank you.
Thank you. Okay, so we can wind up the session. Thank you. Thank you all for joining and good night. Namaste.